not working only with the RPPF clinics in the region, but also we are making sure that private laboratories are part of the national response. And that means that they have to follow the national protocols, and they have to be sensitized, and that really feel responsible of the work they are doing, and not just giving the result like something that doesn't matter. And of course, the BB condom and lubricant distribution through commercial partners, that is also part of another way of working with the private sector. Important that is a cross-cutting issue in the program is gender. It's included in all the activities, but there are some specifics, like training with NGOs and journalists. For the first time, we're also working with that population, journalists and opinion leaders. We already created a database, and we're studying with all these sensitization, you understand me? Program and trainings, and developing materials for them. In Guatemala, we are part of a violence commission. We are already a commission recognized, and thanks to that, we got some extra funds from PEPFAR for a gender-based violence initiative. And some specific activities like for the International Day Against Homophobia and Transphobia, we did some DTL activities, and we're always in that. Well, result 4, this is just an example, just this year. There's nothing for the big list they have, but this year we are going to conduct tracks in each country of the region for sex workers and for MSM. We have 6 countries, so 12 tracks. Plus, for the first time, we're going to do a people living with AIDS and men at risk regional track. We also do MAP every 2 years with the focus on segmentation. We just completed the stigma and discrimination and the masculinities study. We are working on impact studies to make sure that our methodologies are proven effective, and we are going to plan to measure the combination prevention approach in general. And this year we are also doing mystery clients in every country to check stigma and discrimination with health providers in the private labs and in the RPPF clinics. Coordination is key. In the program, we are working close with all the USG agencies, Global Fund, the Ministries of Health, US embassies, the Department of Defense, Peace Corps, and CDC. Well, PSI has a global agreement with Peace Corps, and is working very well in the region. This is important because this program cannot be done alone. We need to coordinate with different levels and sectors. I already mentioned some of these things, but this again, coordination, this Violence Commission is part of the Vice Presidency of Guatemala. They lead the commission, and UNAIDS, USAID, PASMO, PASCA, that is another bilateral program, are part of that. In El Salvador, we work very close with the Ministry of Health and all the process that we are following for the national economic strike. And something important to mention that I didn't want to leave out is Mexico. Mexico regional is part of the program, but unfortunately, at the beginning of this year, the program was cut due to all this new cut and focus strategy. So right now, we are only working with MSM, trans, and drug users, only in 2 cities that are Ciudad Juárez and Tijuana. We had to reduce activities in Mexico City and Guadalajara, and 4 cities had to be eliminated. We're still doing combination prevention, trying to follow the components, but the original activities were completely changed. Basically, we are doing some PCC activities, but just to measure, because our commitment now is to live in the country proven methodologies, that then the country can or someone can give continuity to this in general. And to finish, this has been very challenging. And I think the most difficult thing was to, like I said, to change the chip internally and externally. So really make sure that everybody was understanding the new approach, the combination prevention approach. context, because we are one region for 6 different countries, and everything changes in each country, so we needed to adapt the strategy to the different contexts. Work with NGOs, because they were used to do activities, like a maquila, I will say. They used to implement, and now it's not just that. They have to implement, but they have to understand that it's something more than that, and analyze the results. Coordination, definitely, as I mentioned, is crucial at all levels. And well, social media, that's new for us also. So we're learning a lot here. And I think the most difficult thing is how we will measure that. And we are on that. So, but it's also very innovative, but at the same time very challenging. Making sure that all partners were speaking the same language, and in general challenging but positive. And well, unfortunately, Mexico cuts. We needed in a month to redesign the program, and it's going to finish next September. But I think we will be able to lead proven models in Mexico. So I think that's it. Yeah. Thank you. Have any questions?
You mentioned on the research component that, well, we're doing a lot of stuff this year. So is that the baseline that we're going to use, and then another at the end of the program to see our impact? Or?
No, we already, the baseline were the 2010 tracks. So we already have baseline there. But the difference is that we are now also including the UIC in the tracks. So in addition to the normal analysis to compare our baseline indicators with our baseline, we will be able to analyze the UIC, and we're also planning a specific research to test combination prevention approach for next year.
And then is there another track at the end?
Yes, in 2014 this will. Yeah.
I have a question and a comment, and the comment is kind of directed to me, but can you just confirm the 19,000, is that individuals who've gone through the entire loop? And I should know this, I haven't heard this the third time today. But the 19,000 individuals, are those, have they completed the loop, or they've just been reached?
No, they probably, there are some that have completed the cycle, some that are maybe have done part of the cycle, and some have, because what I was telling you, the description of the PEPFAR indicator description of the minimum package and the combination prevention is different from ours.
Yeah. Okay.
And so we have to report those numbers according to the PEPFAR description, but we are tracking our own minimum package and combination prevention.
Okay. And I just wanted to say too that Kim and Amy are both here. Susie just presented at USAID this afternoon, and they had a number of questions about measurement, and she mentioned that, and I think we talked about this, I was knew about this, trying to identify resources for an impact assessment of the program, which is something NBD, you guys always ask, where, tell us where we can point our gun in terms of looking for resources. But again, this is just this is on the horizon. This type of program needs to be measured. They mentioned in there in a side conversation that there is limited evidence that combination prevention works. And some of their questions were kind of evidence of their old model. There was a comment, well, your numbers seem low. But if you think about it, I mean, and I can't remember what the number is for the number of people that have closed the loop. We're talking 6 months. These are people living with HIV and trans. I think the person that asked that question, Shanti Conway, she missed the beginning of what the specific populations are. But 6 months to go through an entire process and adopt some new behaviors, that might not be that low, and we need to be able to articulate that. And the other thing they ask for is cost effectiveness evidence, and we need to be able to articulate that.
Well, that's another question I had. So you have built in some sort of evaluation for exposure to channels, right, for the behavior change communication part, but not necessarily the combination of all 3 of those tranches, right? And that's what we want to do.
Exactly.
So which combinations work.
Exactly.
But then what about the social movement part? Susie, that's going to be part of it. Yeah,
and
it,
part of it.
It would be a part. And so is USAID not, they don't have any money to give to this?
Of course they're non-committal. No, they were to completely silent with the, we're looking for money, we brought it up. But
Yeah.
so, I mean, there needs to be, they're working on a concept note to be more.
Well, Free IE
directive.
is just, they just announced their submission of open requests, that we could actually put one in for Free IE.
Actually, I and Rebecca are working on the concept note process.
Yeah. Why don't we,
just have a
that
draft
announcement
estimate.
just came out like today, so we could put one forward for that. That's good. Yeah.
Yeah, because at the end, we don't have enough budget. We don't have budget in the program to do
Yeah.
something really well done. So we decided to develop a concept note and start looking for resources.
But as Donna said, I think more and more they're looking for external evaluations and organizations trying to
Yeah.
tap into those funds. And we haven't been great at doing that so far, but I
Yeah.
think we are kind of going over the hurdle and trying to get better at it and
Yeah.
partnering with people and trying to identify.
One other question that somebody might be interested in funding, I was writing this down, because you talked about the advocacy, you talked about duplication among donors. I mean, what an interesting question, because you've got the unique identifier code, you could see if there is duplication. And that would be a really interesting thing for a World Bank, or I don't know, somebody
Definitely.
else to fund.
See, yeah, that's why at the end Global Fund accepted but really agree with the idea of using the same UIC. We just to be able to negotiate that in Guatemala, we had a lot of meetings, and we just had a recent visit of the Latin American Global Fund Director. So we sat down with them and we talked about the UIC, and now they are piloting because they wanted to pilot it themselves.
Right.
But that is one of their objectives, to really avoid.
So have you guys planned in some analysis of duplication
Yeah, for
efforts?
sure.
You have,
Yeah.
okay. And you have enough support on it? Because
That's something that we need.
that's also maybe something where we want to tap into a partner for. Sure. I have other questions for both of you.
Susie, thank you. That was great. I have more of a macro question than a macro question. So it sounds like you track your USCs through the voucher system. So the USC is written on the vouchers. So we've tried vouchers in many other places, and sometimes they work, but a lot of times they don't. Either because we give a voucher to somebody and then they don't bring it to the service because the service is either low cost anyway or free, or there's people don't always carry those kind of things with them. So what has been your experience with the voucher?
That is happening.
Yeah.
It's happening, definitely. That's why we don't see the voucher for the future. No, really the voucher has helped us to introduce the concept. Because I have had a conversation with NGOs, and they were telling me, why you are spending a lot of money printing vouchers if I have seen people that have more than 7 vouchers? And my answer was, why are you working with that people again? You should look for others, because if you already know that has 7 because they are already have the message here. So that's why they are really starting to use the data. And for me, for us, it's more important than the USC. But we need the vouchers because the USC has to become like natural, the number, your phone number. You have to say like that. But it's helping because when you have something. So that's why we also have other monitoring funds. We have the vouchers, but in the near future, all vouchers, probably the green ones, because that is the first green, that one should have this, but all the others should, and that will depend on how we will see, or maybe with some populations first and then some others.
And Susie, how do we select or design the BCC activities that we carry out, and how do we know that they work? I think you mentioned
Don't know those, well, based on evidence, the tracks, and we identify there the bubbles and the factors that influence more behavior, and based on that, we develop the methodology, some participatory, some one-on-one, and the behaviors that are the behaviors that we want to change. So it's a combination of, combination is like a fashion word now. It's a combination of factors, but yeah, we use and qualitative also. So
I have a quick question about the target populations. And do we find that there's some that are easier, or that this model works for more than others?
workers are easier. They are used to, there are more friendly services to them, and they are, women are easier to, it's easier for women to go to the doctor. I think the most difficult are trans, because there are not too many friendly services, and that's why we are working with all on the result 2 and with all these clinics to make friendly services, but not specific services, but friendly. And MSM, because most of MSM are hidden in our country, so we have some difficulties in really identifying if they are not, and this, but yeah, there are difficulties in depending on the target. People living with AIDS are not difficult.
I have a question that builds on Mike's point. I guess one thing we could do, because you have those unique identifier codes now, and they'll be in the track. We could run some cluster analyses to see what are the difference. What are the profiles of people who complete or just scrub or only access part of the service? And I mean, that's also something to work with Moon on. You know, that's a different approach to the analysis. Because I know those tracks get really large and the scales haven't worked very well in the past, but we could change the way we look at that analysis. And it could be completion of the course or completion of the package. The other thing, you know, the power of your vouchers, Susie, is it could help you get out of the dally ghetto a little for those services, for the services that you get, that you promote, but you don't get. So those referral cards, you can track them back. If you get 50% of the dally, you can track for VCT and STI.
Right. But it's good because, especially for the
Biomedical companies, the vouchers, all vouchers are coming back.
Right.
Because
that's one advantage of keeping them, is it is a way for you to track then who actually got the service as a result of exposure to your project. And so if you have those numbers, you can be working with probably Kuti to get, would be Kuti to work on the referral? Nene and Kuti, okay, sorry, yeah, Nene, to get credit for that.
We'll do it.
But basically,
That's done.
that's what I told Susie when we was in the class today, because there was a question about the cost per person, which
Right, you could do a cost per dally.
Cost
so
per
actually
dally,
we can have that for cost per
Yeah,
dally
we
or
could
cost infection items.
Right. You
Yeah.
could, because all of that's built into the dally model, so you could do a cost per case averted or a cost, yeah.
And would that cost, sorry for the ignorance, but would that cost also relate to any way of getting the cost effectiveness of the intervention also?
Well, you can do that, yeah. I mean, that's how we report cost
Because
effectiveness
that's
globally.
one
So,
of the things they're interested in,
so that's the simplest way to do it,
Yeah.
because we have that available for you to do.
Sure.
So that's,
Something that's what a lot of donors are looking for now is like
Sure.
how ongoing are you going to measure cost effectiveness? And we have that, I mean, we have the annual thing, but I think they're looking for a more deeper analysis.
sure, but you could build that into those impact evaluations, because you figure out which ones are most impactful and then you tie a cost to it. You know, which is more like a process that's adding up the cost of delivering that service. So, the other one's a cost per impact.
Sure. Are they very expensive?
Depends on the design. So.
Okay, not to beat the UIC thing into the ground, but I have one other question. Because back to what Beth is saying here about the UIC, part of the problem with the redemption and the collection is, and you said that we're disproportionately focused on Africa, but there's not a, I think in many of the countries where we're trying to advance this, they're not regularly collecting these. There's not the service providers. They don't value the utility of collecting the referral cards. And it seems like there's something that you've done to either collect, even if it's not the referral card, the UIC, or to record it and document it so that you have some way of tracking. Have you worked with the service providers so that they are consistently asking that question? Because it's not, part of the reason with the UIC working or not working is that no one's collecting that information once a client reaches to the health center. They don't ask, they don't value it. It doesn't matter if they have a referral card or not. There's just no.
But we do, because we collect them.
But have you done something with the health providers too, or was that something they did anyway? Is that something that they
we
done?
have worked with them. You know, in some cases, and we have tried to make it easier for them.
Okay.
You know, I was just telling to you because in some cases, every time you want to receive a medical service, they make you your file, your expediente in Spanish. They collect everything we need for the UIC. So in some cases, we're telling just give us that information and we'll do the UIC, and they learn how to. So they don't have to be asking the questions to collect the UIC. That's one thing. Another thing is that most of the cases, educators, NGO or our educators, when they give you the pack of vouchers, they already write the UIC in all the vouchers. So nobody else has to collect it. You just have to deliver the voucher. And then it has required meetings to make them understand that that information is useful for them and for us, especially with the private sector. But there has been like different actions that we have done, and if I'm not wrong, even in one country we work together to adapt their system to collecting the, with Claudia, they work together to adapt their system, because we don't want to change the way they do things to the voucher. So it's not just like giving it back. It has been there's a process that countries have followed.
Okay.
And also, working at a high level, because especially with the public sector, when direction comes from the top, they have to do it. So, and we have done that.
Okay.
Okay, so thank you very much for being here.